my disclosure. So today I'm going to talk about modern radiotherapeutic management of diffuse low-grade glioma in the molecular era. So my disclosure. So so since 2015, the term low-grade gliomas has been used to describe gliomas which are WHO grade 2 or 3. And historically, grade 1 and grade 2 gliomas were referred to low-grade gliomas and were considered clinically distinct from their more aggressive grade 3 counterparts, which were termed anaplastic gliomas. Both grade and various glioma subgroups, including oligodendroglioma and astrocytoma, were previously based primarily on histopathologic appearance and characteristics. However, following the landmark publications demonstrating that molecular markers such as IDH mutation and 1p19q co-deletion are better able than histologic appearance to prognosticate outcomes in patients with gliomas, the distinction between grade 2 and grade 3 has become more blurred. Lower grade gliomas with an absent IDH mutation tend to behave more like a glioblastomas. And these and other findings led to the revised 2016 WHO classification of tumors of the CNS, whereby the histopathological findings continue to determine grade, but molecular characteristics were preferred to define glioma subgroups. So based on the revised 2016 WHO classification, well, 2016 actually is the year when I joined UW. So at that time, we started to use these terms as designated by WHO classification. So most notably, tumors with IDH mutation and 1p19q co-deletion are molecular oligodendrogliomas and have a more favorable prognosis. Those with IDH mutation but without 1p19q co-deletion are IDH mutated diffuse astrocytomas or molecular astrocytomas and have an intermediate prognosis. Those lacking IDH mutation are IDH wild type tumors, diffuse astrocytomas, or molecular glioblastomas, and have a poorer prognosis. So, in 2021, the classification system actually reshuffled everything. So, based on the 2021 designation, it continues to classify grade 2 and 3 diffuse gliomas using this integrated histopathological and molecular classification. However, relevant key changes include the category of IDH mutated astrocytomas, WHO grade 4 based on the presence of microvascular proliferation, necrosis, and or CDKN2AB homozygous deletion, which is distinct from IDH, a wild-type glioblastoma, which continues to be defined histologically by the presence of microvascular proliferation and or necrosis, but also molecularly by the presence of a TERT promoter mutation and EGFR gene amplification, and the gain of 7 and loss of 10 chromosome copy number changes. So based on the WHO classification 2021, so for IDH mutated astrocytomas, the molecular markers include IDH1, IDH2, ATRX, TP53, and CDKN2AB. So why is CDKN2AB that important? So when there's a homozygous um, deletion, actually the behavior is more like grade 4 tumors. It's basically similar, to grade 4 tumors. And for oligodendroglioma, IDH mutated, and with a 1p19q co-deletion, the markers, apart from 1p19q, include IDH1, IDH2, TERT promoter, CIC, FUBP1, and Notch1. And for glioblastoma, which is always IDH or wild type, would include a IDH, of course, and TERT promoter, chromosome 7 and 10, chromosome 7 and 10, and also EGFR. So here's how they classify, just make it simple. So for adult type diffuse gliomas, first you look at whether the tumor is IDH mutated or not. If it is wild type, and regardless of the grade, if there's a TERT, if you see a TERT promoter, and if you see EGFR mutation and also 7+10- chromosomes. So automatically the patient would be designated to having a glioblastoma. And if it's IDH mutant, it's actually, much more complicated. So first you look at whether it is 1p19q deleted or non-deleted. If it's deleted, then if there's a third mutation, it's oligodendroglioma. And if 1p19q intact with with a ATRX loss is astrocytoma. And among those gliomas, astrocytomas with IDH mutation, so if there's a CDKN2AB homozygous deletion, it automatically bumps the grade up to grade 4 regardless of the grading based on the histological appearance. The entity, which is not included, is like, what if there's only, a single copy lost? Actually, it was not addressed in the WHO classification in 2021. And this is, an area I would, include later on, in the presentation. So in terms of the radiographic appearance, what is um, unique is in a small number of tumors, actually, you can see the T2 and flare mismatch. So on T2, you can see, there's a T2 signal hyperintensity, which is more homogeneous, but, on the flare, you can see like the central hypodensity there. So this is actually pretty characteristic of IDH mutated gliomas. It doesn't occur in, all the tumors. It's only in a small proportion of tumors. But, when you see that, I think is quite, you can be quite sure that is IDH mutated. So there are, very few trials addressing just the grade 2 tumors per se. But again, with the new classification system, I think some of the results of some of the grade 3 trials may be relevant because, with the under this molecular classification, patients with IDH mutation actually, grade 2 and grade 3, they're not too different. In fact, in the current NRG oncology trial, comparing protons versus photons, they include grades 2 and 3. And actually, for both groups, they use 54 grade, which is a low grade glioma dose. So, I mean, people have done that, and so far, I don't, really have any long-term data to tell you whether it's as good as like in the olden days we give 60 grade for grade 3. We don't have the information. So the RTOG 9802 basically changes the practice. So I'll include in the slide later on. Um, Before I think 2013, actually before 2015, before the results of his trial was published, actually based on the Congress of Neurological Surgeons guidelines for diffuse low-grade glioma, actually it said chemotherapy actually is not indicated because it's not effective. But in that particular study, they included high-risk patients, which were defined as patients older than 40, or patients who did not achieve gross total resection. And they compare with patients receiving a radiation therapy alone, a radiation therapy followed by 12 cycles of the PCV chemotherapy. And what they found was actually pretty striking. So when they look at the molecular markers, when they actually look at the outcomes of patients based on the WHO classification of 2021, so IDH mutated tumors with also 1p19q code deletion, the survival was actually more than twice. I mean, it's around, twice. So I remember that was in 2014, 2015. I was still working in Case Western Reserve University. Actually, my chair actually is the deputy chair for the whole cooperative group NRG Oncology, Dr. Mitch McTay. And then when the results were released, when we had some patients who we tried to, bump up the dose of 54 gray, at that time, we were concerned about, okay, these patients are going to live for a long time, and we really do not, we need to add chemo, and we don't want to, overdose the patient because, we don't want to give the patient um, excessive complications if the patient um, lived for a long time. So it's around like a 14 years versus 7 years for those patients with oligodendroglioma based on a molecular classification. And for those with IDH mutation, but without co-deletion, still it was pretty significant. It's 11.4 years versus a 4.3 years, which is actually very, very significant. And the progression-free survival. Let me see. And the progression-free survival was also much higher compared to, yeah, so I took it back. So for the oligodendroglioma, actually the median survival was not reached, for the combination group, the, PCV plus radiation versus radiation. Even with the radiation group, the median survival was a 13.9 years, which is just crazy. And for the astrocytoma IDH mutated, the median survival was 11.4 years versus 4.3 with radiation alone. However, for the IDH wild type patients, the median survival was only 1.9 years, which is slightly, more than, the survival for glioblastoma. So this trial actually completely, changes the management of low-grade glioma. So initially, when they reported the results, I think they did not, break down the molecular characteristics, and later on they did a genomic analysis, and this is led by Dr. Erica Bell, who was a previous colleague at Ohio State Medical Center. I think she was hired by Nino at that time. So she looked at all the patients and look at the molecular markers, including IDH mutation and 1p19q deletion. Here are the results. So when you look at IDH mutated and 1p19q, status, the highest, the oversurvival, so, the group, among the whole group. So they're just looking at molecular characteristics. They mix the patients with both arms together. They just go by the molecular characteristics. So the uppermost curve is the oligodendroglioma by molecular analysis. Is, the 10-year over survival is around like 80%, regardless of whether the patients were getting radiation or combined PCV and radiation. And the middle group is the patient um, was the patients with IDH mutated astrocytoma, and the 10-year survival is around 50%. And for the IDH wild type is actually, is the lowest, is around 25% in 10 years. And so when you look at the um, multi multivariate analysis, the factors affecting the survival include whether the patient's getting radiation therapy versus radiation therapy plus PCV, or whether the patient has IDH mutation with 1p19q co-deletion, and also whether the patient had IDH mutation. So when you break down further, I think this one is patients with IDH mutated and co-deletion. So the 10-year survival is actually 95%, with chemoradiation, radiation followed by 12 months of PCV, versus around 70% if the patient, were getting radiation therapy alone. And when you look at the IDH mutated but non-co-deleted gliomas, is actually worse. But there's also a separation of the curves among patients getting radiation plus PCV versus radiation alone. So in 10 years, it is around a 65% versus only about 30%. And when you look at those patients that are IDH wild type, whether you give radiation or radiation plus PCV, there was actually no difference in the overall survival. 10-year survival actually is around 15 to 20%, 25%. So this was the original CNS guidelines for diffuse low-grade glioma. It was led by Dr. Javosen, from Emory University. So the key questions at the time were, number one, what is the optimal role of radiation therapy in the management of adult patients with newly diagnosed low-grade glioma in terms of improving outcomes, and what radiation strategies, and also do specific factors identify subgroups with a better outcomes following radiation therapy. So these are the recommendations, which is, by today's standard is obsolete. And specifically, they did not recommend chemotherapy. And actually, in 2015, after they published that the landmark study led by Dr. Jen Buckner from Mayo Clinic, they've changed recommendation on chemotherapy. So it was recommended that chemotherapy to be added to RT in all patients of newly diagnosed low-grade glioma. So I think they may need to make another change because um, this initial study actually did not um, actually, do the genomic combination of the genomics, like, the paper that was published in 2020. So they, in that guidelines, it was recommended that, patients with oligodendroglioma younger than 35 and those who had undergone more complete resection have significantly uh, 10-year overall survival and progression-free survival when treated with RT and chemotherapy than patients with radiation alone. And IDH mutation was a positive prognostic factor. And the prospective randomized nature of the study with appropriate length and quality of follow provided class 1 data to make that recommendation. So, and then in 2020, um, the Congress of Neurological Surgeons initiated, an update, for the guidelines. I think the issue is, it has taken forever, to collect the data, and then, with multiple reiterations leading to like the delayed publication. And also since the yeah, since the publication of since this project was started, the genomic analysis actually was released. But the problem is, based on the Congress of Neurological Surgeons guidelines, you cannot, add that, to this because you already initiated the process. So the search was only up to 2020. So here's the search process. So the when you look at the Prisma algorithm, so we have put up around 550 papers related to radiation therapy, and out of the screening, there are only 7 publications included for the evidence tables. So the first question was, in adult patients with pathology confirmed that ratio grade 2 diffuse glioma, is proton therapy superior to standard therapy result in terms of overall survival, progression-free survival, local control, complications, and neurocognitive preservation or quality of life. So out of 67 studies eligible for full text review, only 4 fulfilled our criteria, and none of the studies directly compare proton therapy with radiation therapy, and three or four of them were written in relationship to one series of patients of low-grade gliomas assessed for proton therapy effect on neurocognition, neuroendocrine status, and quality of life, and they all came from MGH. So the fourth study was a retrospective series examining the incidence of those treatment-related effects and pseudoprogression with proton therapy with versus without concurrent temozolomide. So the recommendation was based on the literature search up to 2020. There's insufficient evidence to provide guidance on superiority and inferiority of proton radiation effect compared to standard radiation therapy and WHO grade 2 diffuse gliomas in terms of outcomes like overall survival, progression-free survival, local control complications, neurocognitive preservation, and quality of life. I think, the main issue is, you know, up to 2020, there weren't actually, really much studies actually, looking at IDH mutated, looking at outcomes of gliomas based on the stratification based on molecular genomics. So the second key question was in adult patients with pathology confirmed diabetes grade 2 diffuse glioma receiving radiation therapy to molecular markers like IDH1 status, MGMT promoter methylation status, and 1p19q presence or absence result in better prediction of the outcomes. So after evaluating 402 studies that fulfill criteria, 67 papers were obtained for the first pass, full text review, and 3 of the studies contained purely diabetes grade 2 diffuse gliomas with molecular marker analysis, and all patients received radiation therapy. So it was suggested that, well, we knew the answer already, since Dr. Gregory Cairncross, from at that time from London Regional Cancer Program in London, Ontario, published data, 30 years ago. It was suggested that 1p19q deletion status could be used as a positive prognostic indicator regarding the effect of radiation therapy on outcomes. So subsequently, American Radium Society, which is Radiation Therapy Society, and FASTRO also published the guidelines. So as opposed to Congress of Neurological Surgeons guidelines, um, so actually we we were allowed to actually uh, uh, allowed to use expert opinion or consensus to put in those guidelines, because for Congress of Neurological Surgeons they have to base everything on the literature. We cannot have any like personal opinion or expert opinion or consensus. So in 2022 we have, I think, both Dr. Hallis and I were on these guidelines. So the first thing we look at is, the appropriateness of postoperative close surveillance for low-grade glioma. So there are several scenarios created. So like grade 2 IDH mutated oligodendroglioma or astrocytoma with low-risk features, which were defined as age younger than 40, with no residual tumor confirmed on postoperative MRI, and tumor size less than 4 to 5 cm. So the first two criteria were based on the eligibility criteria for the RTOG 9802. And the 4 to 5 cm is actually based on the EORTC, which is the European Trial Group definition. So it is usually appropriate if you watch after the resection, if there are no high-risk features. And for the same tumor, but with a few high-risk features, like if the patient is older than 40 with residual tumor, or the original tumor size is larger than 5 to 6 cm, and if there's neurologic deficits, it is a less appropriate, but may be appropriate in certain circumstances, like if the patient doesn't want to undergo any treatment. And for grade 2, without molecular characterization, oligodendrogliomas and astrocytoma with low-risk features or few high-risk features, and based on consensus from the colleagues. So I think in that panel, I think there's one neurosurgeon, Veronica Chang from Yale. She's the vice chair of neurosurgery there. It may be appropriate. And what are usually not appropriate? So if you have the same type of tumor, but with high-risk features, like other than if you have even if the most favorable histology and molecular characteristics, like grade 2 IDH mutated oligodendrogliomas or astrocytomas with multiple high-risk features, which are defined as, age older than 40, or presence of residual tumor size larger than 5 to 6 cm, with neurologic deficits. These patients should not be watched. And for grade 3 tumors with the same molecular characteristics, or grade 3 tumors without molecular characterization, whether it's oligo or astrocytomas, one should not be watching those. One reason is, if it is IDH wild type, it can behave like a grade 4 tumor, or sometimes even glioblastoma. And if the patient, even if there's the IDH mutation, but if the patient has homozygous double copy loss of CD KN2AB, those patients are basically grade 4 patients, so you should not, take the chance. And for IDH wild type low-grade gliomas without microvascular proliferation and necrosis, although histologically it's not glioblastoma, but these patients, there's a likelihood that, at least, these tumors would behave like a grade 4 tumors, as you can see in the RTOG 9802 study, IDH wild type grade 2 gliomas. The median survival is only 1.9 years. It's basically slightly better than glioblastoma. And so for postoperative monotherapy recommendation or combined modality therapy for low-grade glioma. So the first scenario is for grade 2 or 3 IDH mutated oligos or astrocytoma, or grade 2 or 3 um, by histology but without molecular characteristics. So just when you're just giving monotherapy or radiation or chemo alone, is it appropriate? It's usually not appropriate, because I think if there's an indication um, to treat at all, I think you either use um, you have to use a radiation therapy, combined with chemotherapy. And for IDH wild type low-grade glioma without microvascular proliferation and necrosis, those patients should not undergo just radiation alone. These patients should get chemoradiation therapy. It is mixed whether you should do concurrent chemoradiation versus um, sequential, which means radiation therapy and then followed by um, um, chemotherapy afterward. So for patients of low-grade glioma following surgical resection or biopsy, when is combination of radiation therapy and chemotherapy appropriate? So grade 2 and 3 IDH mutated, whether it's an oligodendroglioma or astrocytoma, or grade 2 to 3 with only histology but with no molecular characterization, oligos and astros, these patients should get chemoradiation therapy. And for patients of IDH wild type, low-grade gliomas, these patients should get chemoradiation therapy. Again, it is mixed whether you do it concurrently or neoadjuvant. But I think, the tendency is, if it is not proven glioblastoma, if it's not molecular glioblastoma, I think people tend to do it like sequentially, because in the European trial, the Ketnon trial, I think the main benefit is on the neoadjuvant group. I mean the adjuvant group, not the concurrent chemoradiation therapy group. So only adjuvant chemotherapy uh, was shown to improve survival in those patients. And among patients with low-grade gliomas following surgical resection or biopsy, when is radiation therapy combined with PCV appropriate? So it is not um, specifically with PCV. So again, the same group, subtotally resected or patients older than 40, high risk features like, with neurologic symptoms, or the initial tumor was bigger than 5 to 6 cm in size. And if it's grade 2 and 3 IDH mutated, whether it's at 1p19q deleted, or if there's no histologic characterization, those patients um, should be getting radiation therapy combined with PCV. And for IDH wild type low-grade gliomas without microvascular proliferation or necrosis, it depends on whether, it behaves based on the characteristics with the other, three, like the TERT, EGFR, and chromosome 7 and 10 changes. If those are present as well, so the patient would have, molecular GBM, and in that situation, concurrent chemorats with temozolomide would be more appropriate. Otherwise, if it's somewhere in between, like it is not grade 2, but is not like GBM, those patients may be more well suited, for radiation therapy combined with PCV or temozolomide. And among patients of low-grade gliomas following surgical resection or biopsy, when is radiation therapy followed by temozolomide appropriate? Again, is pretty similar to the PCV recommendation. And yeah, this I already gone over. So Astro also issued a guidelines in 2022. Is actually our director of CNS radiation oncology, Dr. Hallis, who led these guidelines for grade 2 and 3 diffuse glioma for the same re reason I mentioned, because right now with the molecular markers, grade 2 and 3, the difference is more blurred. So Dr. Jason Shin is also on the panel from UVA. So again, the recommendations are um, based on the molecular characteristics. Like for oligo, IDH mutated, 1p19q co-deleted, and if the so indications for radiation therapy and the timing for radiation therapy. So for patients, with grade 2 less than 4 to 6 cm with gross total um, resection, those patients, can undergo surveillance safely. And for patients with a similar tumors but with high risk features, um, we have to, offer radiation with sequential chemotherapy or radiation with concurrent and sequential chemotherapy. And for patients with oligos, IDH mutated 1p19q code deleted, the basal grade 3 with any extent of surgery, upfront treatment of radiation and chemotherapy is highly recommended. And for IDH mutated astrocytomas, and if those tumors were small in size with gross total resection, and if there are no high-risk features like the patient is a younger than 40, close surveillance alone may be appropriate. However, for any other situations, um, radiation with concurrent or sequential chemotherapy is conditionally recommended. And for patients with IDH mutation, WHO grade 3, any extent of surgery, um, either radiation with sequential chemo or radiation with concurrent and sequential chemo is highly recommended. So in terms of optimal dose of radiation therapy and target volume definition, so in general, I think the around a gross tumor, we actually need to create a margin, which is around 1 to 1.5 cm to account for any microscopic extension. And the PTV, which is a margin to account for the daily set of variation, is around 3 to 5 mm, which is pretty standard. And we usually use FLAIR or T2 to define the GTV. And in terms of the radiation dose, I think if it is like a low-grade glioma, I think based on the literature, there's a no dose response, between 45 and 59, um, and actually between 45 and higher than 6,000. I mean, that's and 6,000. However, I think, right now, in most centers, we would give 50.4 to 54 gray with 5.5 to 6 weeks. And actually, for some grade 3 tumors with favorable molecular characteristics, like, IDH mutated and 1p19q code deleted, and also, when there's no CDKN2AB um, uh, double copy loss, those patients actually, can be treated with 54 gray instead of a higher dose. Because these patients, they're expected to survive for a long time, and we don't really want to give the patient a high risk for complications like radiation necrosis or neurocognitive deficits. So, um, so in terms of radiation techniques, um, as I mentioned before, I think for proton therapy, there's no um, level and evidence to support its use, although in the ASTRO guidelines, it is recommended, but the strength of recommendation was conditional, and also the quality of evidence was low as of now. Usually we use IMRT or VMAT. And for patients with IDH mutated WHO grade 2 and 3 diffuse glioma, assessment, surveillance, and management by multidisciplinary team is recommended for toxicity management. And this is highly recommended, but it's based on expert opinion. So these are the side effects that can happen, with radiation therapy for low-grade glioma. Neurocognitive deficit, neuroendocrine dysfunction due to the radiation dose to the pituitary gland and hypothalamus, neurologic deficits depending upon the location of the tumor, vision, and hearing. A lot of the temporal tumors, when we irradiate, the cochlea, ipsilateral cochlea can receive a pretty high dose. And sometimes some patients could, lose some hearing, from the damage, to the cochlea, and permanent alopecia and cerebral vascular complications. This usually would occur, many years down the road. So what I tell patients is, I think, although, you cannot remove the risk of your vascular complications, from the radiation, but actually the risk of stroke is multifactorial apart from the damage to the blood vessels. Also, the patient's background situation, like, the blood, you know, lipid, cholesterol, blood sugar, blood pressure, if they can actually get those things controlled, at least, on their part, they can control, decrease the risk of a stroke in the future. And, financial and social toxicities and quality of life measures. So I'm going to go over this trial, which has also, changed some practice. The Indigo trial. This is a randomized trial of the use of an IDH inhibitor called vorasidenib versus placebo for residual and recurrent IDH mutated low-grade glioma, and they enrolled 331 patients. And this study showed an improvement of progression-free survival, which was the primary endpoint, with the use of vorasidenib, 27.7 months versus 11.1 months. And it was associated with an overall response rate of just 10.7% and a combined complete and partial response rate of only 1.2%, with no notable difference in the rate of stable disease between the two arms. 82.7% with vorasidenib versus 88.3% with placebo. So based on this study, FDA actually approved a drug for the use in low-grade glioma patients with residual recurrent tumors, 5-day mutation. So the progression-free survival with the use of this agent was modest, with nearly half of the patients having disease progression within 2 years. And this is, what I've observed, at our clinic. And this 2-year progression-free survival of 50.7% was substantially lower than the rate of 85% observed with standard chemoradiation therapy in a high-risk cohort of RTOG 9802. So yeah, there's a few criticisms of this trial. Number one, the control arm was actually placebo and not radiation therapy and chemotherapy, and should have been chemoradiation therapy, because the patients included in this trial, particularly the group with residual disease, but not those who had recurrent tumors, they would have been treated with chemoradiation therapy based on the RTOG definition. But those patients were offered placebo, and this is the control arm. And the second thing was the trial allowed crossover from placebo to vorasidenib. So basically, in my mind, right off the bat, those patients who should have been treated with chemoradiation therapy, they ended up just getting nothing, just placebo, half of the patients. And then when they recur, again, they would be crossing over to vorasidenib rather than getting chemoradiation therapy. So in a way, they were denying standard of care twice. So the third criticism was, I think there was a question of some questionable clinical relevance of endpoints used. because what they used as the primary endpoint was the imaging-based progression-free survival, but it may not completely correlate to the overall survival and quality of life. So based on this study, the American Radium Society, the guidelines that I just showed, issued an update. And so the recommendation was, vorasidenib may be appropriate for recurrent or residual IDH mutated grade 2 oligos or astros, and it's usually not appropriate for completely resected grade 2 oligodendroglioma or astrocytoma, or any grade 3 oligodendroglioma or astrocytoma, or combined with radiation or chemotherapy for any grade 2 and 3 gliomas, because simply there's just not enough data. So finally, I'm gonna, touch on a specific entity, IDH mutated tumors, but with single copy loss of CDKN2AB, which is an important marker, when there's double copy loss in terms of determining survival. So the University of Heidelberg group, as you know, this is actually a premier group in radiation oncology. They were the pioneers in like a carbon ion therapy and proton therapy for brain tumors. So they had 334 low-grade glioma cases with 173 astros and 161 oligos. And they had like 37 of the patients out of 173 astrocytoma patients who had hemizygous deletions, and they had 15 of 161 in oligos with hemizygous deletions. And actually, when compared to the wild type cases, um, there was actually no difference in the survival. So what is the conclusion? So in the clinic, when we see patients with like WHO grade, say for example, is a grade 2 or grade 3 um, astrocytoma IDH mutated astro or oligodendroglioma, and if there's just a single copy N2 CDK N2 AB single copy deletion. So although, I have a high tendency to treat even if there are no high risk features, but actually the dose I use, I would actually, use the low grade glioma regimen, because again, when you bump up the dose, the risk of radiation necrosis is higher. So I'm going to touch on proton therapy versus IMRT. So I'm sure that you all heard about it, with proton therapy, because what we call a Bragg peak. This is the regular X-rays. So the beam doesn't stop; it just goes through and through until it attenuates. But for proton therapy, actually, you can, put a Bragg peak here. That means the radiation dose will stop at a particular range here. And this is, what we're showing here. On the left-hand side, you can see a proton plan, treating a patient with a left temporal tumor. There's virtually no radiation dose in the involved brain, versus for IMRT, even with advanced technique, you still have some intermediate and low dose spillage there. So, right, is a silver bullet, but not always. So, the issue with proton therapy is, at the end range, over the years, what we have discovered is, there is some uncertainty in what we call the relative radiobiological effectiveness. That means at the end range, the biological effect actually can be higher than what is shown on paper and in the numbers. And even when we use the radiobiological models to like a look at the the actual radiobiological dose given. Sometimes, we really couldn't figure out. This is an example of a patient who had WHO grade 3 IDH mutated tumor who got treated with the proton therapy. So the three beams, one, came from this side, the left side, left anterior oblique, and one beam coming from this side, the left posterior oblique, and there's one beam actually coming from the top, like the vertex. And then I think 4 to 6 months after the treatment, so the patient was seen by one of our neuro-oncologists, saw a lesion like that there. It's kind of like radiation necrosis. So these changes are, we have seen that before in different patients treated with protons. So we actually went back and, look at the radiation dose delivered to this area right here. So this is exactly, where, the lesion um, was located. And we look at the radiation dose. Actually, it occurs in a relatively low dose range here. It is around, I would say, like, 3,000 to 3,500 centigrade. And these changes we actually never see with photons. So I think, if the lesion occurs in an area where the patient would unlikely would not would not experience any symptoms, I think it should be okay because eventually I think the um, the changes, would die off. But if it ends in areas like the brainstem of the optic apparatus, it could create a problem. So when we, look at the, how we arrange the beam, so what could have happened is, so this beam actually, like ranges through this area, the left anterior oblique beam. So the Bragg peak, ends there, and the radiobiologic effect may increase. Although we're using three beams, that actually, when we look at, the other beam coming from the top, this also ranges through there. So two of the three beams ranges through that area. So that may explain why we see these changes. And also, I have talked to Dr. Hallis about this, and actually what she noticed is, so we have two different technologies. In the olden days, we have something called a uniform scanning beam. So it's a one whole beam scanning through the area. Compared to uniform scanning beam, right now we have pencil beam, which means we have individual small beamlets. It looks like, right now, we're seeing more of these with the pencil beam, and maybe a different technology contributes to the difference in the biological effect, at the end range. So there's a study which was also open here, but it's closed right now, randomized study comparing protons versus photons for the IDH mutated low to intermediate grade gliomas. We're waiting for the results of this study. So the endpoint was cognitive preservation. So this is the summary slide. So what do we do? So in simple terms, for IDH wild type tumors, we don't offer proton therapy because I think because of the relatively short-term survival, the patient may not benefit from that. And for um, IDH wild type tumors, you know, we we use this we give the high grade glioma dose, which is like 60 gray. We use the Stu protocol or the Canadian hyperfractionated protocol, which is 40 gray in 15 fractions. And how about the IDH mutated tumors? If we have grade 2 to 3 tumors with no CDKN2 AB, you know, loss, or if it's a single copy loss, we would use radiation therapy followed by PCV or temozolomide. Or in patients with low risk features, we can actually safely observe grade 2 but not grade 3 patients. And vorasidenib is reserved for patients, of course, with residual tumors or recurrent tumors who refuse any treatment, who refuse chemo or radiation. We have actually managed some patients like that who refuse standard of care. But eventually, after 2 years, the tumor progressed. They had to undergo chemo radiation. And for grade 4 tumors, we use the Stu protocol or the Canadian hyperfractionated protocol, particularly when the patient has a low performance status. So that wraps up my study. This is the CNS low-grade glioma panel at this Congress of Neurological Surgeons meeting. I remember, when I walk into the conference hall in Washington, D.C., the first voice I heard was Dr. Ellen Bogan's voice. Hey, Dr. Lowe, what are you doing here?
Oh, I knew you were invited, but uh, thank you, Simon, for a great a great talk in covering the complexity of the molecular markers. I thought you did a great job, and it was good to see the science, at least the trials that were behind that. And we only have time for one question. Anybody have a singular question? I mean, you covered so much. Um, Anything, talk about personalized medicine.